And thank you for joining us again for the second half of our program today, Medoscopy. As mentioned in the first half, our second guest for today is Dr. Maria Jacobs. Dr. Jacobs heads radiation oncology here at Mercy. Dr. Jacobs, how does one become a radiation oncologist? How does that work?
How did I become a radiation oncologist is the definition of serendipity. I didn't know what I wanted to be when I finished medical school a few years ago in my country. And a friend of mine and I, were just wondering, what do we do? I did work for a few months in a HMO, trying to figure if a primary care, will be a field for me. And one day, my friend got an interview with a very famous radiation oncologist in Caracas. Not only he was famous for being very highly into the radiation oncology practice, but he was also the chief of radiation oncology and nuclear medicine in the university hospital. And I just went along with my friend for her interview. He saw me in the waiting room, and he asked me what I was there for, and I told him. And he said, I think that in sympathy for your friend, you should come along and be interviewed as well. I didn't dare say no, because he used to be a big professor at home. And at the end, a couple of days later, my friend called me and said, you got the job, and I couldn't believe it. Because I had no idea about radiation oncology, but I knew that I could basically have a future because of the kind of equipment and the kind of science that radiation oncology involved. Right there in that afternoon, I was very interested in what he was doing with a brand new piece of equipment that I never knew what it was, and that was the first time that I saw a linear accelerator that has become, the machine that I used every day of my life, since then. So it was just by serendipity that I got this job as an intern. We did radiation oncology in this brand new machine. We did nuclear medicine, so we were able to scan all our patients, and we also did a little bit of medical oncology. So I was exposed to that kind of multidisciplinary clinic, just a month or two after finishing medical school. And that is how I became interested in what he was doing for cancer patients, because we were seeing the patient right after surgery. We didn't have surgical oncology, so the surgeon was very accustomed to say, the diagnosis is cancer, it is the job of the radiation oncologist to take care of you, and that is how we were able to interact with that kind of experience. So it was a multidisciplinary setting. But the center of that center was a linear accelerator. So I was excited because before that, we used to do cobalt. And cobalt was a very different type of radiation machine that no longer exists, but in probably Smithsonian museums. So I got introduced to very contemporary style of radiation oncology practice very early in my career. So that opened my eyes to a very, fascinating experience.
Now, you mentioned Caracas. You're originally from Venezuela.
Originally.
Earned your medical degree there. What was it like coming from Venezuela to the United States and making that transition?
Wow. It was shocking because I didn't speak any English. I was invited to do a research fellowship with another interesting and exciting radiation oncologist in the United States. He was an inventor and a developer of techniques and equipment. And because of that experience with my mentor, he invited me to have an exposure to what research in cancer was all about. He knew that I didn't speak any English. He was German with a very strong accent. and I landed in a Black historic institution, which is Howard University in Washington, D.C. My experience there was great because guess what? I was not the only one with an accent. Back in the days, Howard welcomed people of color from different countries. I knew people from Afghanistan, any country in Africa, Haiti. So when I arrived there, it was a very impressive experience to be surrounded by non-English speaking people, yet doing fantastic work in medicine. Very early into that fellowship program, I interacted with residents and other trainees. So they basically helped me to gain a degree of confidence in speaking whatever came out of my mouth. So it was a transition that it was at times, so somewhat painful because I missed my home, I missed my parents and the family and friends, but I met very interesting people. There were different days in America, and I think that people were very welcoming when I arrived in Washington, D.C.
Now, in our first segment with Dr. Friedman, he mentioned the work that he does with you with IORT. What's that collaboration like?
This has been a great experience here at Mercy because we became the first institution in the state of Maryland to do intraoperative radiation therapy for breast cancer patients. In my background, interestingly enough, when I was at Howard University, it was my American mentor who introduced IORT for other tumor sites. We had a program in which our patients were patients with typically locally advanced cancers, pancreas, rectum. On occasions, we treated a brain, but we were using IORT with a different type of equipment, the equipment that we ordinarily use for external beam radiation. So when I joined Dr. Friedman in developing the IORT program at Mercy, it was an exciting transition, from locally advanced, deeply situated tumors to such a easy access anatomical site like the breast.
We'll take another break and come back for our final segment of Medoscopy.
In tonight's Woman's Doctor, women who have undergone a lumpectomy for breast cancer usually need to return to the hospital for weeks of daily radiation therapy, but technology is eliminating that need. Listen to this. This procedure is called targeted intraoperative radiotherapy. The technology is called IntraBeam, and here's how it works. Radiation is delivered inside the breast during surgery, immediately after the tumor is removed. It's one large dose that minimizes excessive radiation to neighboring tissue.
So it's an ideal dose of radiation to prevent a local recurrence of a cancer, particularly in patients with breast cancer.
Specifically early stage breast cancer. Mercy Medical Center Dr. Maria Jacobs says the procedure is also a good option for patients who fear multiple visits to the hospital during the pandemic and might not otherwise complete their treatment.
Now, you mentioned you had a American mentor. I always like to ask the physicians about who their mentors was. Can you tell me a little bit about that?
Well, my American mentor was my German, professor. His name was Ulrich Henschke. It is a kind of funny what happens in the scientific world. If you ask a newly graduate radiation oncologist, have you heard the name of Ulrich Henschke? And they are going to say no. But Dr. Henschke was the developer of a technique that we call remote afterloading. It is a way to treat a tumor using radioactive source, mandating a piece of software to stay in that tumor for a calculated period of time. We do these techniques, for instance, in patients with gynecological cancers. We have used it as well for patients with breast cancer when we were doing breast brachytherapy. So it's a technique that at the time, when I was a resident under Dr. Henschke's leadership, it was very primitive. We were using cobalt sources that require a lot of shielding, and that it requires a long time of exposure of that particular tumor to the radiation. In today's day, we have a piece of equipment called HDR, high dose rate, remote afterloading, and we can deliver big doses of radiation to small volumes in a short period of time. Well, the origin of that technique, was in the hands of Dr. Henschke. He also created devices that we use for the treatment of cervical cancer, one of the most common gynecological tumors. And we use it all the time in collaboration with Dr. Dwight Im and Dr. Rosenshine. And there is one of the devices named after him. So to have had that experience coming, from my very beginning in the United States, make me feel like I was trained by the giants. One in the United States and the other one in Venezuela. I consider myself, Lou Gehrig will say, the luckiest woman on the face of the earth, because I was really very lucky to have professors who had a sense of research, that is always so important in our field.
Now, as our viewers know, one regular feature of our program is a kind of a show and tell, where guests bring in something, some item, could be a book, could be a photograph. We really don't know what until they show up with it, but it's important to them in some way, symbolic of who they are and what they're about. Dr. Jacobs, what have you brought for us today?
Okay, well, we have been talking about my mentors here and my professors. And I mentioned Dr. Vera, the name of my mentor in Venezuela, and then Dr. Henschke, my mentor here in the States. There are two people that obviously without them I would have never been here and been mentored by these two individuals, and these are my father and my mother. The show and tell that I bring is two objects that I have as a very sweet memory of the two of them. My father was a founder of Sears Roebuck of Venezuela in 1949, 1950, when the company opened the first store in Caracas, Venezuela. And as a founder, approximately 30 years later, he was recognized by the president of Sears and by the president of my country with an award. And he was, among those awards, he was given this button that is a representation of the Sears Towers in Chicago. So my father was very proud to have this button in his lapel, and my mother gave it to me before her death in remembrance of my dad. So I take this very close to my heart because it is what my father represented for a company of this big name back in the days. The second show and tell is a memory of my mother. This is a medal that was imposed by the president of my university and the dean of my medical school on the day that I graduated many years ago. So in honor to my mom, I just gave this medal to her. And before her death, she decided to return these two awards to me. And those are two things that I precious and value in memory of my parents.
Dr. Jacobs, and for Dr. Friedman, who's not with us at the moment, but was here earlier, thank you both for your time and your candor. I'm hoping our viewers enjoyed this chance to hear your stories, learn about some important topics, and maybe learn a thing or two that they can incorporate into their own lives. On behalf of myself, our guests, the Mercy staff, and the Sisters of Mercy, we wish you, our viewers, good health and humor. And until we meet again, may the road rise up to meet you. and you stayed all the way through the credits. Great, because now you'll be able to enjoy our Wait Doctor, I Forgot to Ask segment. This is where we talk to physicians about that question patients really wish they had remembered to ask and forgot, or that question that doctors really wish their patient would ask and don't. Dr. Jacobs, what's that question for you?
When am I starting this radiation? Why not now? Why not tomorrow? This is supposed to be just as easy as to take a chest x-rays. Not really.
Well, why not really?
Not really, because to start a plan of treatment with radiation therapy requires precision and exactitude. So we need a planning process, and that is what it requires before the patient start the radiation therapy. So what I usually tell my patients is that be ready for us to discuss the rationale for the treatment, how do we deliver the treatment, what it involves, what your reactions are going to be, and how I am going to avoid those reactions from ruining your quality of life. So that requires a planning process. That it takes probably a week before you start your first radiation treatment.